Good morning, everyone. My name's Rebecca, but you can call me Becca. I'm a physical therapist at Back at Work Physical Therapy in Provo. I've been coming to these rounds since like October, November, and I'm so happy to be asked to present today. So thank you, Amelia. Thank you, Dr. Bowden, for everything. So we're going to talk today about lumbar spine connections. Okay. So I have no disclosures, and here is your case study for the morning. Okay. Very basic, 73-year-old woman with generalized low back pain and mixed urinary incontinence. Does everybody know what mixed urinary incontinence is? The difference. So it's a combination of stress urinary incontinence, like you cough, you sneeze, you blow your nose, you have a little bit of urine leakage, and urge urinary incontinence, which is I have to pee, I got to get to the bathroom right now or I'm not going to make it. Okay, so what do you want to know about this patient? What's her birth history? Good question. She has 9 children, 8 vaginal births. One set of twins. What else do you want to know?
Is the back pain affecting her function?
Very little bit. The urinary incontinence is really what is affecting her function. Can't do very long drives. Feels nervous when she goes to church. Things like that.
Does she have the urinary infection problems for a while, or is this a new thing?
So it's not a urinary infection, it's the incontinence. If I misspoke, I'm sorry.
Is that a chronic thing? Or is that new?
That's a generally new thing in the last 1 or 2 months.
How long has the back pain been going?
A couple years, not very long. And it's more of the incontinence that is bothering her versus the lumbar spine pain.
Medications?
Nothing of really significance.
Nothing for the back, nothing for the urinary incontinence.
You had raised your hand. I thought you had. One of you. You, sorry.
What is her bladder? I'm assuming you had a bladder diary. Get a general idea of how much she leaks.
Yeah, so she's leaking a couple times a day. So this was on initial eval, hadn't really gotten that information yet, but enough that she's showing up. She was referred to PT for the pain and the incontinence. Yeah. Anyone else? Okay. So this is a pelvic floor patient, and I'm a pelvic floor physical therapist. And so I'm excited to talk to you today about, number one, this patient in general. So this patient, 73 years old, with low back pain and mixed urinary incontinence, improved in 1 week of just pelvic floor exercises, hip strengthening exercises. She came back to me a week later and said, I don't even need you anymore. I have no more incontinence. My back pain is gone. I don't need you. So what does a pelvic floor physical therapist want to do talking to a group associated with brain and spine surgery? What am I doing here? What am I doing here today? Okay, well, let's talk about it. Okay, and let's start with this study right here. Okay, so 2 groups of women with generalized low back pain. Okay. Group A received stabilization exercises and pelvic floor exercises, and Group B just received lumbar stabilization exercises. So 6 weeks, 3 times a week. At the end of the week, both groups have improved, okay? But the group that received pelvic floor strengthening exercises improved significantly more. Okay, so by paying attention to one of the most important areas of the body, we see better outcomes. Okay, and why is this? Why do we see improved outcomes when we add pelvic floor strengthening to a generalized low back program? Anybody? Okay, well, I'll tell you. Okay, and it's all about the connections. So the connections between the pelvic floor and the low back are between muscles and fascial connections, okay? So almost all of the pelvic floor muscles have attachments to the ischium, ilium, pubis, the pelvis, okay? And we have fascial connections pretty much from the diaphragm all the way down through the hips of the pelvic floor. And so when I talk about the pelvic floor, I talk about it as a box. So our pelvic floor is the floor of our core, okay? With the top being the diaphragm, the bottom being the pelvic floor. In the front, we're really focusing on the transverse abdominis. In the back, we're talking about the multifidi. And so in a normal or healthy functioning body, these are all working together, and it's all about timing, right? Before we reach for our cup of tea, our multifidi should be coming on and our pelvic floor should be turning on as well. So when we forget the pelvic floor, we're missing a very important component to get better outcomes. Okay, so what does a pelvic floor therapist treat? Okay, and so my question is really, what does a pelvic floor therapist not treat? Okay, we treat anything from dysfunction breathing to incontinence, to pelvic floor prolapse, to bladder spasming, anything that has to do with urinary, bowel, sexual function. Like I said, disordered breathing, low back pain, hip pain, okay? So we encompass everything, okay? So what happens with a pelvic floor evaluation, okay? Well, it's not unlike a regular physical therapy evaluation, okay? I want to know everything in the subjective intake, right? Where I'm adding, what's going on with past pregnancies, what's going on with the urinary, the bowel, sexual function. I want to look at their posture. I want to see how they're standing. I want to see how they're walking, how they're moving. How are they picking up a baby off of the floor, okay? Are they using their pressures correctly? What's their strength like, their range of motion? And then when it comes to the actual physical therapy evaluation, I tell people you have one of three choices. Number one, we have a choice of an internal evaluation, right? So what I'm looking for is coordination of the pelvic floor musculature. Are they able to coordinate a Kegel? Now I know most of the women here know Kegel. Does everybody know what a Kegel is? Yes, I'm getting pelvic floor lift. Are we able to turn the pelvic floor on? Are we able to coordinate it with the breath? Okay. Then, are we able to relax that pelvic floor? Is the pelvic floor so tight that there's no functioning happening there and they cannot release that, which will lead to another host of problems, okay? Second option is an external examination. So clothes on, my fingers are right between the ischial tuberosities, and there I can feel whether the pelvic floor can lift or can it release, okay? And last option is no hands-on assessment, right? Their body. I don't have to put my hands on your body in any way, shape, or form. And so I always put that decision into the patient's hands. What do they feel most comfortable with? Okay. And so what about treatment? Okay. So the answer in physical therapy, we like to say it depends, right? It depends. Is the pelvic floor too tight? Is the pelvic floor not tight enough? Is the coordination not there? Okay, so we like to look at the body globally, but here's another study that I love, okay? Sometimes we don't have to even talk about the pelvic floor, even for pelvic floor incontinence. Okay, so in this study, 2 groups of women, self-reported SUI, remember that's the sneeze peak group, okay? So one group of women has stress urinary incontinence and one does not. And we test all the things on these women. What's the difference? So shockingly, the answer was not in the pelvic floor, okay? Both had similar pelvic floor endurance and strength, okay? But what was different was their hip strength, okay? So women who had self-reported SUI had a reduction in hip strength, specifically in the external rotation and the abductors. Okay, if you're a PT, you can guess everything comes down to hip external rotators and abductors. So we should be strengthening on all patients. So this is great news for patients who can't figure out how to coordinate their breathing with their pelvic floor. I hate to group, but generally older people cannot, they've never had to think about diaphragmatic breath and turning their pelvic floor on. So sometimes getting them to do that isn't gonna happen even after 4 or 5 visits. We address the hips. So sometimes we can decrease stress urinary incontinence by just strengthening the hips. I think that's so cool. That's so cool. And we can flip that on a separate coin. We as physical therapists can determine maybe the problem isn't even in the pelvic floor, maybe it's in the hips. I had a young gal, new baby, second time mother, who was referred to me for slight urinary incontinence. And we determined the problem was not her pelvic floor at all, but it was an FAI. So we were able to refer her to a surgeon, get her FAI. I've never looked at her pelvic floor again. Everything got taken care of by just having that one hip surgery. Okay.
Quick comment.
Yeah.
I guess more of a story. My wife had pelvic floor issues. She had a baby, was cleared at 6 weeks to return back to activity, and she started running, pushing a stroller.
Mm-hmm.
And she had a hamstring strain. And she was treated by 5 different providers over a 3-year period.
Mm-hmm.
And no one could solve her issue. And at one point she came home and she just said, I'm in so much pain, I literally would cut off my leg.
Mm.
And she was just in tears almost every night for 3 years. And finally we saw a pelvic floor therapist and did an internal vaginal exam, pushed on obturator internus, and that was her pain.
Yeah.
So this stuff that you're talking about is probably one of the most misdiagnosed back pain things that we see.
100%.
The majority of people that don't get better with back pain treatment typically have a pelvic floor issue.
Mm-hmm.
We just don't know
Exactly.
until you test it, and then it's very apparent.
Yeah. Yeah, it definitely stands out. Yeah. Yeah, I love that. I wish that I could go back before I became a pelvic floor therapist and treat years worth of patients and go back and fix the situation. Yeah, I feel like it's very missed. And let's be honest, people get squeamish about the pelvic floor for obvious reasons, right? It holds our sexual organs. Nobody wants to talk about that. It freaks people out. But once you get used to it and you realize that so many of the problems are there, whew, it's game changing. I love that. Okay. So this is the fun part, okay? Pelvic floor fun facts, okay? Number 1, you guys, men have pelvic floors too. Oh my God.
What?
Yeah, it's true. It's true. Yeah. So, number 1, we basically have the same muscles down there, right? Just different external structures, right? In fact, the woman that I talked about, the case study, she came back after 1 week. She told me, I don't need you anymore. I did, by the way, I did keep her for a couple extra weeks to really get that hip strength solidified. But she said, I don't need you anymore, but can you help my husband? Okay? He was leaking bowel and bladder. And so this young man who's a couple years older than her comes in. You actually happen to be walking through. So he shared with me the first time stuff he's never shared with his doctor before concerning incontinence, had never mentioned to a medical doctor. We don't ask, we assume everything's okay, right, if it's not brought up. And so at one point I was like, is there anything else you want to tell me? He's like, I didn't want to tell you the stuff I've already told you. You know enough, right? And so this is not just a woman's problem. This is a people's problem, okay? Now, this is where it really gets interesting. There is a relationship between temporomandibular joint dysfunction. I've got notes here on this one because there's so much. And pelvic floor concerns. Has anyone heard of this before? Okay, so this is awesome. Okay, so here's the reason why. I've got like 5 reasons why. Number 1, day 15 of our neural development, of our development in embryo, we have 2 different depressions that end up, one being right next to each other. Ends up being the mouth, and the other one being the pelvic floor with the urethra, the vagina, and the anus, right? They start at the same time, they end at different points, right? So that this theory is not dissimilar to trigger point therapy in the muscles. Okay, we have fascial connections, right? The pelvic floor and the TMJ is not that far away, and we've got the fascial connections that run through the trunk. So that's one theory. The next theory is traditional Chinese medicine. Has anyone here had acupuncture? Oh, it's so good, huge fan, right? So in the gallbladder meridian, so very, very basis for traditional Chinese medicine, there's energy channels that run throughout the body, and we can have energy blockages that can cause all kinds of dysfunction. You put needles in that, for some reason it clears up and you get better. If you've never had acupuncture before, I love it. But the gallbladder meridian runs through the jaw and ends in the pelvic floor. There's another connection, okay? The vagus nerve comes out of the skull, runs through the back of the tongue, through the vocal cords, and lands in the pelvis, right? Another connection. And this one's kind of fun, a study that I'm really kind of glad I wasn't a part of because I don't like scary movies. But some Vandervalle et al. In 2000, 2001, which feels like yesterday, but it's not, did 2 studies with scary movies, right? And they monitor muscle activation during jump scares. And there is similar muscle activation during jump scares of scary movie in the pelvic floor and the trapezius. And for TMJ dysfunction, the trapezius holds a big component there. Isn't that interesting? I just think that's so cool. That's so cool. There's also a correlation with hypermobility syndromes and pelvic organ prolapse, which is structures of the pelvic floor falling down, whether it's bladder, rectum, or the uterus starts pushing down. And it changes with different pressures of the body, which makes sense, right? Hypermobility disorders, we have a disorder in the collagen of the connective tissue. And that's what's holding our pelvic organs up, is the connective tissue. Okay, so if is dysfunctional, it's going to be dysfunction in the pelvic floor too. I find specifically with these patients, the hypermobility patients, that even though the pelvic organs are falling, the pelvic floor is incredibly tight, right? And so there's probably nothing to support this, but in my observation of the human body, if you've got everything that's loosey-goosey, your body has to find stability somewhere, right? And it seems to always go to the pelvic floor. So for these patients, if I decrease stability in the pelvic floor, now we're gonna have even more problems, okay? So now we're really working in, we're not even looking at the pelvic floor at first. We have to create some more stability in the body before we even start addressing pelvic organ prolapse, okay? And now for you spine doctors, this is a big one. Hold on to your seats, okay? So they have found that disorders of breathing and incontinence have a stronger association with low back pain than obesity and physical activity, which I think flips a lot of things on its head that we don't think about. So that's why we love pelvic floor physical therapy. Okay. And then just one more thing, just to give you a little bit of humor on your Tuesday morning before you guys go out and do good work. Okay? Any questions?
What are common things that you would suggest to the group to be able to identify if someone had these types of issues to send them to you?
Yeah, that's a great question. I think it's just asking questions, right? Like, it's very easy to do a quick clearing a question like, are you having problems with bladder, bowel, or painful sex, right? People are uncomfortable having those questions because we don't do it, but once you do, then you can't stop talking about the pelvic floor. So that kind of changes, right? But just a very quick clearing question.
Yeah, I have an Olympian downhill skier.
Yeah.
She's 19 years old. That's been treated for low back pain for 9 months.
Yeah.
She lost 3 scholarships, and she's qualifying for the Olympics right now.
Oh.
And she's going to Chile. She has all these trips planned, but she just cannot get there. And we started treating her, and I just thought, oh, maybe there's a bunch of stuff that we've missed, low back pain. And I started treating her low back pain, and I treat pelvic floor all the time.
Yeah.
And then we were just plateauing at like 75% improved.
Mm-hmm.
And she's like a month out from going to this Chile trip to go skiing. And I'm just like, what are we missing?
Mm-hmm.
And this is something I treat all the time. But
Yeah.
19-year-old, I cleared her for, she's never had intercourse, she's not sexually active, doesn't have leakage, literally never had an OB appointment. So I just thought, there's no way she has pelvic floor issues.
Mm-hmm.
I started pushing her on externally, sure enough. Her obturator internus, which is typically the one that is the overactive one, super guarded. So you talk about if someone's loosey-goosey, right, she's going around and hitting these G-forces in these turns, she has to find stability somewhere.
Mhm.
So she guards and tightens her pelvic floor through these turns, and that's what's reproducing her pain. So initially she actually had low back pain, but then it converted into this compensatory pain. She's compensating through her pelvic floor, trying to stabilize as she's hitting those G-forces, and that's reproducing the exact same back pain that she has. So
Mhm.
we go in internally, vaginally, release those muscles, retrain them, and she's already significantly better.
Love
So
it.
we're
Love
at
it.
like our last visit now, and she's doing extremely well. But these are just little things that we
Yeah.
just neglect, and the reason why it crosses over into the low back. It's just like the heart. When you have a heart attack, you typically feel it in the shoulder. You don't feel it in the heart. So that's why the pelvic floor is so misunderstood, because it could be an internal problem, but it feeds up. The obturator internus actually attaches into the hip. So that's why it can cause hip pain, and it refers up into the back as well.
Mhm.
So it's just one of those things where it's like, it's so confusing. If you don't check it, you don't know.
Mhm. And the obturator, the levator ani attaches to the OI, so it's all connected in there. Yeah, I love that.